Welcome to the OR Today webinar series. We are excited to have you join us for our very last webinar of 2020. This year, OR Today webinars have provided an easily accessible educational platform for more than 2,400 attendees and have presented continuing education certificates for more than 1,200 viewers. I would like to remind you, today's webinar is eligible for one continuing education hour. The post-webinar survey link will be emailed to you 1 hour after today's webinar. I'll have more on this at the conclusion of the presentation. OR Today would like to thank our sponsor, Healthmark Industries. Since 1969, Healthmark Industries Company Incorporated has developed and marketed innovative solutions to aid healthcare facilities in the delivery of surgical instruments and other life-saving medical devices to patients. Healthmark Industries' mission is to continue to innovate, continue to support, and continue to serve the healthcare provider industry and support services that make it possible to deliver the quality healthcare. Visit hmark.com for more information. We will have a question and answer session at the end of the presentation. If you would like to ask a question, please use the question feature on your webinar dashboard. Our presenters today will provide an overview of the importance of the use of checklists in healthcare facilities as a significant step for patient safety. Along with improving patient safety, checklists create a sense of confidence that the process is completed accurately and thoroughly. Our panel today will feature the following experts: Stephen Kovach, Clinical Educator Emeritus; Seth Hindy, Clinical Education Coordinator; John Whelan, Clinical Education Coordinator; Kevin Anderson, Clinical Education Coordinator; and Jahan Asizi, Special Projects Manager. Steve, you may begin whenever you are ready.
Hello, everybody, and welcome. How you doing? We want to thank you for coming today, and we're going to find out if you're naughty or nice because we're going to do a checklist and check it twice. Excuse me, there we go. Disclosure. As with any presentation given by Healthmark Industry, we're employees and we work for a manufacturer and distributor. We did not receive any compensation for this presentation. All the opinions are ours as the presenters. This presentation is not intended to be used as a training guide or promotion. Before using any medical device, review all relevant package inserts with particular attention to the indications, contraindications, warnings, precautions, and steps for use of the device. Also, if we cite any literature, standards, or guidelines, just as we said, you need to read them completely. We are going to use them to help make our point, but you still need to read the complete standard or the article yourself. Healthmark has a policy. Our policy is to provide our customers and the healthcare community with the highest quality state-of-art medical products and support service in a timely and a cost-effective manner. This goal is supported by a staff committed to individual accountability, professionalism, mutual respect, collaboration, and service excellence. This presentation is part of that commitment to educating our customers. We believe it's more than just buying a product or running a test. It's about having clinically relevant, evidence-based products. It's about support for Healthmark products, both clinically and educationally, with the understanding that an educated customer is our best customer, and that then is the best person to serve the patient, one who is educated. Who am I? I'm old. They say sometimes old as dirt. Been around since 75. Worked in a lot of different things. I do like to say that I've worked in the heart of the hospital, central processing. Many of you know that I like the tag, keep it clean, but I also have another one, and this is very important. Some say knowledge is power, but I believe real power comes when we share our knowledge with each other. Today is what we will do, share our knowledge with each of you. So let's start sharing that knowledge. So Today we're talking about checklists, and we have 3 points we want to highlight today. We're going to describe why the use of checklists is an important step to protecting patient safety. We're going to outline how checklists are used in endoscopy, sterile processing, OR, and biomedical engineering, show how these all dovetail together and how we can work collaboratively. Then identify the different types of checklists that are used in those areas of healthcare. So I'm going to start it off. Describe why the use of checklists is an important step to protecting patients. Well, I have a honey-do list. I wonder, does that meet the requirements? In fact, I had one today. A checklist is a type of job aid used to reduce failure by compensating for potential limits of human memory and attention. My wife will agree to that one. Yes, I do forget things, and a checklist is important. It helps to ensure consistency and completeness in carrying out a task. All items that need to be included should be included. No items should be included if they don't need to be checked, and items should be listed in logical order so they can be easily followed. Well, sometimes I miss a few. So do you think a honey-do list fits the definition I shared? Well, I think we have to go a little more deeper than that. And the reference is on the bottom left-hand side where I got this information. The benefits of a checklist is organization. Checklists can help us stay more organized by assuring we don't skip any steps in the process. Checklists motivate us to act and complete tasks. I'll use my honey-do list. I don't want to miss one because I don't want to get in trouble. Okay, I'm known for getting in trouble. Anyways, productivity. By having a checklist, you can complete repetitive tasks more quickly and efficiently, and hopefully with fewer mistakes. Creativity. Checklists allow us to master the repetitive tasks and utilize more brain power for creative activities. Delegation. Yeah, my wife does like to delegate. By breaking down tasks in specific tasks, checklists gives us more confidence when delegating activities. She knows if she gives me that list, it's going to get done. Excellent. Checklist allows us to be more effective at taking care of customers, and checklist saves lives. Checklists can literally save lives. That's what we're here today. I've been talking about a honey-do list, but I'm going to use 2 quick little stories here. During World War II, when the B-17 bomber aviator crashed, the pilots and everybody realized there was something missing. They realized they had to put a checklist to do all the steps. Somebody forgot something. That checklist concept is today in every airplane, wherever you fly, a checklist is used. And we hear it referenced all the time. The next one is it saves lives. We know it does. And the best example that I was able to research is central lines. Checklists have been shown to greatly reduce infection. It had been noted that doctors, and if any of you are out there, I'm sorry, you do miss things every once in a while. It showed that they skipped different parts of that procedure 25% of the time. The solution was to ensure a nurse also confirmed that the checklist was being followed by the doctor or the physician, and that went down. Checklists save lives. Checklists are only as useful as our ability to achieve each step. I am now going to hand it over to John Whalen. John?
Thanks, Steve. Thanks very much. Hi, everyone. I'm John Whalen. I'm one of the clinical educators for HealthMark. My area of focus is endoscopy and high-level disinfection. I am a registered nurse. I've been in healthcare over 40 years. My career has been in emergency and endoscopy. I worked 20 years in endoscopy as staff, educator, and then 15 years as a clinical manager. Next slide, please. In this section, let's consider checklists as they relate to endoscopy and processing. The concepts are applicable to other procedures as well. A little later, you'll hear from Kevin, who will focus on similar concepts as they relate in the OR setting. When you look at the Oxford English Dictionary reference to checklists, they include it's a list of items required, things to be done, or points to be considered. In healthcare, we have the added significance of the responsibility for individual patient safety. That elevates the importance of checklists far beyond any one reminder or data point. Next slide, please. In life, as well as in our professional healthcare careers, we use both physical and mental checklists. Running errands, you may have a list written down, or you may rely on a mental checklist. This obviously is a common time of year right now for both physical and mental checklists as they relate to the holidays. You may use mental checklists. You may review mental checklists as you're going to sleep, when you're waking up, when you're standing in the shower, when you're driving your car. In healthcare, a lot of what we learn through our formal education, as well as our on-the-job trainings and experiences, foster the actual mental checklist that we use before certain tasks. For example, I learned through my academic preparation, my formal training, how to administer medications through various routes. But in actually performing that task, it became mental checks that I relied on each time to make sure I had the correct patient, the correct medication, and the correct dose. Next slide, please. I want to just pause for a moment and differentiate between checklists and audits. So audits can have a very formal and very punitive connotation to them. Common examples in healthcare are external accreditation agency audits, as well as the internal audits that we have for systems and processes. Generally, the intent of an audit is to provide an official examination or inspection of a process. So audits do use checklists to audit in a standard fashion, but they also rely on observation and dialogue. Checklists should then be considered as tools. Yes, they're tools that are used commonly in formal audits, but as we pointed out, we use them formally and informally throughout our work and our everyday lives. Next slide, please. Steve referenced the origins of the pilot's checklist. Such checklists are often used as the hallmark example to emulate for any pre-procedure or pre-surgical timeout. These are meant to be like pilots checking and double checking to make sure everything is good to go before takeoff, as a purposeful step in the process for every team member to agree that it's safe to proceed. What this is doing, it's recognizing the need for safety and risk mitigation. We verbally validate that the patient is correct and safe. We validate that the equipment and supplies are present and in working order. And we validate that what we're about to do with the patient is correct. Next slide, please. During any given procedure, we aren't necessarily conscious of using checklists, but we routinely do. So evaluating, documenting vital signs is in fact using mental checklists based on training. And when it comes to procedural documentation, whether it be on paper or electronic, it's based on the concept of checklists. Vital signs and medications are entered into a table format. Charting by exception is very much common in procedural areas. When that is the framework, the assumption is that a mental checklist drives whether further detail is required. In the actual process of taking biopsies during an endoscopy procedure, for example, the endoscopist states open, then close to instruct us when to open and close the forceps. We repeat it back because we're verbally checklisting, if you will. When staff are changing for breaks or lunches mid-procedure, we use mental checklists to identify the sedation totals and the biopsy sampling to that point. Next slide, please. Similarly, at the end of the procedure, we're using both physical and mental checklists to identify the sedation totals and the biopsy totals for the procedure. And then we're relaying that information to the endoscopist that writes a procedure report. And we don't release the patient to recovery necessarily because we completed check marks on a physical checklist. Rather, it's our clinical assessments that form the basis of a virtual checklist that guides our actions. Then when it comes to the point of use treatment, or otherwise known as pre-cleaning for the endoscope and accessories, it's very common that we rely on a mental checklist to direct the steps that we perform. In my experience as a manager, I actually promoted the using physical reminders for pre-cleaning right on the procedure carts, because in the hustle and bustle of one procedure after another, I really wanted the information to be in their faces, if you will, as a reminder to complete all these very important steps in the process. Next slide, please. So the procedure's over, patient's off to recovery. Let's focus on the example of a reusable endoscope to be processed. What you see here is very much an oversimplified list to represent the basic steps that are common to both high-level disinfection and sterilization, from clinical use through processing to storage. Both physical and mental checklists should guide best practices in each step of the process. We also use checklists when we evaluate processing competencies for staff. So let's consider checklist examples for a few of these steps. Next slide, please. I reference the example of a checklist queue for point of use treatment, pre-cleaning for the scope. Here's examples of simple step-by-step checklists for the pre-cleaning steps to be completed, and they're individualized to the model of the endoscope. As I mentioned, my preference was the best chance for reminder and compliance was having it posted. This further shows that checklists don't always translate into a form that has to be completed. Yes, the time of point of use treatment or pre-cleaning needs to be communicated to the processing staff, but you don't have to check off that each step of pre-cleaning was done if it's part of standard best practice. Next slide, please. Throughout the multiple steps of processing, checklists should be driven by manufacturer's instructions for use. Operationally, this takes on various forms: paper, electronic references. For example, sites have posted part or all of a given model endoscope IFU in the actual physical area of processing. Similarly, for sites that have computer workstations and tracking inventory software, the steps of processing can be shown on a screen right nearby. Or actual reprocessing posters from the endoscope manufacturers are also commonly used as physical references. Next slide, please. Even after processing is complete, the concept of checklists is important as part of quality control. Checklists are used to monitor storage limits, also known as hang time, for flexible endoscopes after high-level disinfection. The actual tag on the scope post-processing is a checklist with standardized information. As part of best practice, checklist principles should also be considered for monitoring and maintaining the cleanliness of the storage areas, the flexible endoscope storage cabinets. Next slide, please. I end my section with consideration of procedural and processing checklists in the post-COVID environment. To give a few examples of post-COVID checklists: training and competencies. So many facilities were completely or partially closed for periods of time. Now that we're having a resurgent, that's happening again. What happened to basic staff competencies? What about the very basic competencies such as hand washing, donning and doffing PPE, device and/or equipment PPMs? These have become even more critical now as we're reopening facilities. What about new competencies, like new policies or practices that have been put in place? What about facilities that have been reprocessing N95 masks? What about new devices, equipment, operations, processing, ventilators, for example, ventilator thermometers? What about new routines for interacting with customers? What about the physical act of disinfecting a space after using it? What about policies? Do they need to now be revised based on new practices? And did you have process changes that didn't already exist but need to, like focused education, re-education about surface disinfection? What about processing of N95 masks? COVID's brought on both temporary and permanent changes in healthcare. But whenever processes change, just like medication, you have intended and unintended side effects. So you need to evaluate the outcomes. Use the concept of checklists to guide your assessments. So now, to talk more about checklists as they relate to sterile processing, I turn it over to Seth.
Thank you, John. As you can imagine, these checklists are going to have meaning across an entire organization. So my little piece will be about SPD. That's because I am an education coordinator at HealthMark as well, and where John specializes in endoscopy a bit. My focus is more SPD related. Although we did plenty of endoscopy processing in the department that I worked at as well. And so I have about 20 years worth of experience, and the last bit being particularly focused on education within my facility. So competencies and checklists mean a lot to me because we use them often. Next slide. Thank you. I just want to show you two documents here from SPD and really call out just how many things these two, what are seemingly simple documents, actually relate to, how much information they convey in the form of checklists. And so this is going to be a count sheet that we're going to look at, and we're going to just talk about accountability, quality, and process, just a few of the things that Steve had mentioned in the beginning that checklists can do. Next slide, please. So if we're going to talk accountability, we're going to do some call outs here. Like we'll bring them out. So the first call out here is who did this and when? And I mean, I know that seems silly, but it's not. And actually that should be built in to all of our things, that kind of accountability and being able to trace processes and products back to their source means a lot. And it's a very simple part of a checklist, but an important one. Now, next we'll call out specific accountability for testing. This happens to be from a set with insulated instruments. Well, if you know anything about insulated instruments, you know that they're very easily damaged, and we had compliance issues with that. And by just simply having this signature on this checklist to say that I sign my name to checking all of these devices for electrical strays, we actually increase compliance tenfold. And signing your name to a checklist really does mean something. And our last call out for accountability would be in the operating room. Now this is interesting because the sheet starts in SPD but transfers through to the operating room, and our OR asked to be able to use it for the start count and the end count of the procedure, and then the nurse would sign off and date, and then these could be filed. So this accountability started in SPD and went all the way through to the OR. Next slide, please. So now we'll talk about quality. So we're looking at the same kind of sheet. What kind of quality can we get? Well, quality of a start count, end count, missing items, we don't love it, but that does happen. Now, all missing items at the facility I worked at were approved, but I need to be able to show that in this checklist. I have to say, here's what you expected to get, here's what you will get. And the other call out for this section is, give me a click, Steve. There you go. Testing the handles. This is a quality thing. We again had people saying, "Yep, I did the shaft, okay," and then we were actually finding cracks in the handles, and so it was a thing where we actually had to remind people, as a full quality step, we need to extend this to the handles. And then my last call out on this one is about making sure that a lure plug was unplugged. That's a very specific step to making sure that this is sterilized properly. And by putting it on the sheet, there was never a question whether it should or it shouldn't. Next slide. And the last little bit is about process here, right? So we've got how this is done, what's the method, and what's the sterilization cycle, because there isn't just one cycle anymore, right? So it's important to know all of those things. My next call out would be for this specific instrument. Now, I want you to know both of these are electrosurgical instruments, but we have a couple of different things because they're designed differently. This one requires a tip protector that's all the way on the right hand side, while the next one is a coagulating electrode, and this one has a little trumpet valve, and so it needs to be lubricated. So here we are again. These are steps to the process that must be followed, and we're just spelling them out in this checklist. And then my last two things here are, what manufacturer are we using? Is there a preferred? Is there a specific one? Or can we accept alternates? This is, again, a thing that needs to be communicated with your operating room. Sometimes on a list like this, there are no substitutions. So where if we click one more time, we'll see that there's a category for alternate product numbers. Well, there were sheets in our organization that said no substitute in that space. So for that, in that process step, we said it's this instrument or it's nothing. And that makes a huge deal to the surgeon who says that that's the only thing that works for them. Now, this is just one sheet. Let's look at another one. Now, this one for me is really about increasing communication between the OR and SPD, which we need. You know, that there's never enough communication between the OR and SPD in my experience. So we'll click to the next slide and we'll look at how we can increase our communication. So some of this is just purely patient safety. So the first thing we want to do is do some confirmation. Click, Steve. Thank you, sir. This one is going to talk about what this case is about. Kevin's going to get into it, so I won't steal his thunder. There are still issues with wrong patient and wrong site surgery. So this is just a quality check. Do I know exactly which room, which patient, you know, date, time, all of that kind of stuff. And then, by the way, I'm the one who picked it. Seth is the one that picked it, and Steve is the one who sent it to the OR. And those communicate that quality. And here we are giving a final checklist, and just a simple one, but these are something that anytime you're handling a sterile item, you should be verifying the process indicators, checking for package integrity, looking for a load sticker, and checking for outdates on your disposable items. And just by putting this in here and making someone slow down to check it, we again increase compliance, and every one of those is going to increase patient safety when you're verifying them. Next slide. And here we're going to increase our just overall quality. We'd had incidents where case cart would go upstairs and someone would say, it didn't have my sponges on it. I was missing all of my lap sponges. I was missing my special scissor set. And again, how do you drive some compliance? Well, we started to say, we're going to sign these. You're going to know if something was missing, there will be a communication, and that communication will be documented. And again, we stopped kind of having that miscommunication and back and forth of, I didn't know it was missing. You didn't tell me that wasn't going to be there. And so very, very simple steps, and quality increases, communication increases. Click me one last time, Steve. There you go. And this was the quality report that would come back to SPD. And I know we don't always want to hear about our errors, but sometimes we need to. And this was a report that was used. If there was any issues, this could come back to SPD and we could do our root cause and get those items fixed. Next slide. And lastly, for me, I just want to make sure you don't think that they're all hard copy, because they aren't. John mentioned mental. Well, there are ways to go digital as well. So many instrument tracking systems have electronic programs that work that way. They can draw attention to critical processes at critical moments. They can prevent errors by requiring certain actions. And then they are a lot easier for data entry and retrieval. If it's already digital, that makes it a lot easier. And then it's great if you can start to get them, as you see, on a mobile device or a tablet, then that makes reporting and compliance so much easier. So digital checklists are a great thing. And now we'll have Kevin give an OR perspective.
All right, thanks so much, Seth. And you know, I have background in SPD as well, but primarily in the operating room, and that's where I'm going to come in and try and speak about checklists in the OR specifically. So I'm not going to go through my entire bio in the interest of time, but that was my primary experience, was the operating room. So that's what I'm going to talk about this time around. So next slide, please. So checklists that have to do with the OR specifically, we have several of them, and they're not limited to what you see here on the screen, right? But we have pre-op checklists, we have circulator checklists, we have the scrub nurse or scrub tech checklist that's preparing for the OR, and we also have the one that most people are familiar with, which is the universal protocol referred to commonly as the timeout. John had talked about how this applies in the endo world, but obviously it applies here in the operating room. And then there's a debrief as well, which is very important in the operating room. Next slide, please. All right, so pre-op checklists are typically performed by a pre-op nurse, and they might include these items that you see here. Again, not limited to these, but in the picture you see, you know, just an example paper version of this checklist. Again, this could be digital, it could be embedded in the EHR, but a nice paper one that's on paper like this, that's very visible, is a great communication tool that anybody can come up and check the status of these various items on a checklist. A good one to call out here is the HCG or pregnancy test, or even the items, those personal items that a patient comes in with, hearing aids, dentures, all those things, all very important. Blood sugar, that's an important lab value. All of these things are going to be checked by the pre-op nurse, and pre-anesthesia testing and all of that stuff could be filled out waiting for the OR nurse or circulator to do their check. So next slide, please. So what's the circulator doing? Their attention is sort of divided into two places. They're going to be really focused on the patient, but they also have to have in mind what's going on in the OR, and is their room ready for each case. Sometimes, you know, the OR is very dynamic, and you could be doing the same exact procedure over and over again all day, or you could be in a room that's going back and forth with different types of procedures that require all kinds of different materials and equipment and all that. So it's very important, very dynamic environment, and that's really set up for a lot of potential errors, and which is why all these checklists are so important. But the circulator is going to be checking the patient's ID. They're going to be looking for two identifiers, whether it's their name and birth date or medical record number and name. Depends on the facility. They're going to be checking whether or not the site was marked, and how are they going to validate, is that the right or correct site, as we say in the OR. Well, they're going to be checking it against what the patient says and reports. They're going to be checking it against the H&P that should be updated, and they're going to be checking it against the consent that that is telling us what procedure they're in for that day. And regarding that consent, sometimes patients aren't even in a capacity where they can sign their own consent. So another layer of complexity is, do they have a DPOA? Do they have somebody that can actually sign that consent for them? And then are those papers for the DPOA actually in the record and available to reference? And then did the DPOA get involved, and did they sign the consent? And then you have the other standard stuff, you know, were they NPO? Did they get their antibiotics? Do they have pre-existing implants? Do they have allergies? And again, did they have that pregnancy test? Unfortunately, or fortunately, however you look at it, there are times where people find out the great news that they're pregnant right there in pre-op. So that is definitely a step that's very important when getting ready for the operating room. So next slide, please. And then what's the scrub doing back in the OR? So hopefully a lot of these checklists are getting done concurrently, right? Because we're trying to do things as efficiently as possible. And even some of those steps that the circulator was doing on their checklist, they could have even been doing some of that prior to that case even starting. But regardless, you have a scrub back in the room. What are they doing? They're getting that case cart, they're checking it for completeness, they're checking it for the instruments and all those consumables. And how are they doing that? They're doing it with a preference card, which is essentially a checklist, right? And it's going to tell who the patient is, what the procedure is, and what the actual preference card is, which is very important. And I'll talk a little bit about that as we go. But that preference card is going to tell you what equipment you need. It might even tell you if you need implants, but that's one thing that's on the list that we should be considering when we're getting a room ready. Do we have the implants that we need? And then when we're getting our room set up, checking those instruments one last time for all those external indicators that show us and tell us that our instruments went through a sterile process, a sterilization process, right? Very, very important. Can't overemphasize that, because that with any of these checklists, they can become second nature or mental, but when we commit them to memory, it also allows us to make mistakes and forget things. Just like Steven said in the beginning, unfortunately, we're prone to forgetting things, even though we repeat them over and over and over again. So we need to really pay attention to the checklist that we create so that we actually execute them accordingly. And we also might be updating in the operating room before that patient comes back. We might be updating our timeout boards, which we'll look at some more too. So next slide, please. All right, so preference cards. These are so important, and one of those things that everybody knows they're so important, but even still, they have a very hard time maintaining them and keeping them accurate. But what's it going to tell you? It's going to give you all the patient information, right? Which I blacked out. That's protected information. But it's going to talk to you about what medications are needed, which is very important, because those are going to need to be ordered ahead of time if you want them on time, right? It's going to talk about the equipment you need, which is also very important, because sometimes you have surgeries going on in other rooms that require all the same equipment, and you only have so much equipment. Sound familiar to you in sterile processing, I'm sure, because the same applies for surgical instruments. You know, if you're very heavy on total joints in a particular day and you only have so many sets, it's very important that you schedule accordingly so that you have enough surgical instrument sets for your rooms. Same with that equipment, right? Next slide, please. All right, so preference cards continued, right? So a lot of information that is very important on these preference cards. So to the top and the left there in that blue circle, that's the procedure that was boarded for this particular patient, okay? And there's a lot of potential problems that can happen with preference cards, but a lot of times when someone comes to you and says, we had nothing that we needed, this was horrible, they did a terrible job. Well, part of the reason that happens is because if you look in the circle on the right, the card that was pulled for that case was actually the wrong card. It was the card of some other procedure that has nothing to do with what you were there for, and that's why you got all this stuff and none of it was what you needed. So it's very important that somebody is checking that the preference card pulled matches the planned procedure that's there on the left in the blue, okay? So that's a big, big opportunity to check right there for correctness. And then you have down below all those, you know, consumable products or whatever that you're gonna need for that case. And you can see there that somebody used it as a checklist. They're literally physically checking these things off. And then if they needed it and they didn't have it at that time, they literally put still, you know, I need it. So, and then later on it was checked off that it was there. So a lot of communication going on with this preference card used as a checklist. Very effective, lots of information, lots of important stuff there. So, and that's just touching the surface of it. There's actually quite a bit more to it than even that. But let's go to the next slide, please. All right, surgical timeout, universal protocol, as they call it. All right, very important, talks about patient info, what the procedure info is. We're going to talk or touch on fire risk for that procedure as well. And what's also important here is that a lot of times in practice, we also include our counts. Usually the count is done before our timeout. Well, hopefully it's done before the timeout. That's the way it's supposed to be done, but we use our communication board like you see there on the left side of the screen. We do all of our vital information, what's the surgery, what's the surgeon patient information, all of that stuff. And then we also add our surgical counts to it, which of course is another very important checklist for safety in the operating room, because we don't want to have any retained surgical items after that patient leaves. That's a huge, huge problem. So next slide, please. So the universal protocol, it actually came out as a mandatory quality standard back in 2004 by Joint Commission, and it was intended for a pre-procedure verification process. It was going to use surgical site marking, and it was going to be a timeout immediately prior to starting surgery. Now, the unfortunate reality is that wrong site surgery still ranks in the top 3 most frequently reported adverse events. So we need to be following best practices. And I want to just call out that one of the most important things here is that anybody who's worked in the operating room is going to be challenged by some of those really well-meaning surgeons that are so smart, and they're going to call out the fact that their timeout process doesn't work. The data doesn't support it. And that's what they're talking about. They're referencing the fact that these wrong site surgeries still rank in the top 3, and that's a huge problem. But I will submit to you that the problem is not the checklist. The problem is how we're handling it. All right. Any checklist, whether it's endo, CS, OR, if they mean something and they're important to you and your team, you got to have everybody's engagement every single time. And I can tell you from personal experience, that is the one variable that is different in every single room, usually based on what the atmosphere is set by the surgeon. Some surgeons are still multitasking when the timeout is occurring. They're doing it exactly wrong. Some surgeons literally stop the entire room. Everybody in the room is involved. That's exactly what you want. And I bet you when everyone's involved and the surgeon has everybody's attention and everybody's speaking to their part of the timeout, I bet you the safety in that particular room is better. So that is something that's very important to call out, is that there is a variance in how we carry out these checklists in the real world, and that is really the source of the problem. The checklist is a great tool, and it always will be as long as you take it seriously. Next slide, please. So there's also a debrief, all right? This is a very important final check in the operating room, because you're going to confirm that the procedure that you plan to do is in fact what you did. You're going to talk about specimens, hopefully, because there's a lot of different things with specimens. You know, how do you prepare it? What fixative does it go into? Or does it go fresh? Or does it go frozen? Whatever it is. We have to make sure that it goes correctly and that it's labeled correctly. We also have to make sure that our counts were correct, all right? And we also talk about blood loss. We might talk about what kind of implants were in there and make sure that they were documented accordingly. And we might talk about what lines or drains were put into the patient at that time so that the post-op nurse is aware. And then we hopefully are going to discuss any problems that we had with equipment and report those problems. One of the problems with anything that happened when it comes to safety, incidents in an operating room environment is that it's so fast-paced, so many priorities all at once, is that things don't get reported. But equipment is a very, very important thing to report if you have problems within your facility. And to talk more about equipment and how it's important and how checklists apply to the equipment side of things, we have an HTM expert, Jahan Azizi, who's going to follow up on that portion.
Thanks, Kevin. That's appreciate that. So as Kevin said, this is John Azizi. I'm Special Project Manager with HealthMark. I'm a certified biomedical equipment technologist and been in the healthcare system for 33 years and mostly at hospital, but also work at medical device manufacturer and Food and Drug Administration as well. Next slide, please. So we are going to talk about the role of healthcare technology manager, HTM, or biomed in the system. So as you know, medical technology maintenance is set of activities that is performed by biomed or HTM to make sure that the devices are in good working condition. Of course, you need to have a pre-purchase evaluation to make sure that the technology that you have is appropriate for your need. But once it comes to the hospital, biomed will do an income inspection to make sure that the meet manufacturer specification and also if there's any damage during the manufacturing or shipment. And they place them on a preventive maintenance based on manufacturer recommendation or risk level that the hospital would come up with. And when they break, they fix them. And you need to document these either in a paper 3x5 cards or nowadays in computerized maintenance management system or CMMS. Next slide, please. So, and as you know, the Joint Commission will look into those when they come and do the survey. They want to make sure that they have a medical equipment committee is established in the hospital. Obviously, you need to do performance improvement. That's a requirement from Joint Commission. And the documentation of your maintenance and what do you do with them. Those are important to make sure that is taking place. Next slide, please. So one of the scariest issue that if you don't do them right with all those checklists is operating surgical fires. These are preventable fires. And according to FDA, when these three elements come together, you will have a surgical fires. If you have an oxidizer, oxygen, which is anesthesiologists usually control that. You have the ignition source, such as electrosurgical unit, cautery, lasers, and fiber optic lights. Those could cause the ignition source. And also the fuel, which is the patient's hair, tissues, skin, and all the activity that you have around that. When those three come together, you have a surgical fire. Next slide, please. And FDA recommends, based on what Kevin was mentioning, that you really need to, part of your huddle, either monthly or checklist or what have you, to make sure that you go through the risk process. You make an assessment, is it above the xiphote, is it open oxygen? And then if you have any kind of oxidizer in place, an ignition source, if you're using laser or what have you, to make sure that you take those in consideration. Next slide, please. And also, as I said, is the scariest one preventable, but while exact numbers are not available, of the 23 million inpatient surgery and 27 outpatient surgeries, according to FDA and ECRI, that they have about 100 surgical fires. However, if you go to patientsafety.pa.gov, the numbers for 2018 was about 650, and in 2017 was around that much, 217 surgical fires. They're reducing, but what you can see that there are some serious injuries, well, in that case with FDA about 20 per year, and some death, 1 or 2 deaths per year. Next slide, please. One of the successful technology that has been used is laser. Laser, which stands for light amplification by stimulated emission of radiation, which unlike light bulbs that you have many waveforms, these have a specific waveform that you can drag to the area and use it for cutting the tissue. So as you can see from here, there are several sources on the web that you can attach. And one of them is AST have really one of the checklists that you can look at as a quality system to go there. We take a look at some of these on next slide, please. That you can see a checklist, obviously, as the higher class, which is they're more dangerous and have higher power. You can see, for example, class 3R, 3B, and class 4 lasers. you have to have a checklist. And one of these issues, obviously, the hospital established a laser safety officer, and most laser during the surgery are basically monitored and by laser tech, then make sure that they actually operate that. And really that has prevented eye skin damage to the staff and the patient during the surgery, but making sure that you go through every step of the checklist and make sure everybody has goggles on, the doors are closed, and if you have a glass that is covered, windows are covered, and make sure there is not reflective surfaces because the laser would bounce and cause damages. And next slide, please. But there are other items in the operating room that they're not getting as much attention as the laser. For example, electrosurgical monopolar and bipolar cords. There are several reported in MOD database that has caused issue. See this one on the next slide, please, that there are some actually caught on fire in the operating room during use. For example, in this particular one, if you go look at MOD database, it said that the surgeon was not getting enough power for 30 watts. So they increased from 30 to 45 watt, and all of a sudden a spark came out and this fell to the ground and obviously was detached from the electrosurgical unit. Next slide, please. So if you look at the IFU for reusable bipolar and monopolar, they said that you need to check them every time. Every time that you use it, you need to use an ohm meter. But if you look at that, I have not seen a lot of ohm meter in SPD department to make sure that they check the continuity of these cords to make sure that they are actually conducting electricity. So, and then if, again, you go back to the IFU, it said there's a warning that if you do not check these on regular basis, that you could cause fire. So, and some of these are 10 use, some of are 20 use. So if you don't have a system or mechanism to make sure that you are using them according to IFU, you could cause damage. And if you go to next slide, you can see that there are buckets of them in the SPD department, that some of them do have really good system that you actually check them. For example, in this area that you see, they said that 20 uses on those, so those are put in a basket or bucket to be disposed of. But it's difficult to really keep track of them. So we had some of the users at the hospital came to us and said, can we have something to check it? On the next slide, you can see that, you know, we came up with this continuity tester, which is pretty easy to use. If it's a green light, it's okay. If there's no green light, that you need to probably pitch that or take a look at those items. With that, next slide, please. Thanks, Steve.
Okay, John, thank you, everybody. We're going to get ready to wrap it up here. And what I want to do is do a quick little summary before we hand it back to Jennifer, and all our presenters will be on screen to take questions. What we've tried to show you today is that a checklist deals with tasks, should be in a chronological order. So there's a smooth transition between each step. Many times it's following the IFU or your standard operating procedure. You can have them in your personal life or in your work. You can have mental ones, as John was talking about at one point, and paper one, digital ones. An audit is a deeper dive, but they're all very important. And Kevin stressed something that was very important, and all the speakers have said it. You have to take them seriously. I know our tagline is making a list, checking it twice, going to find out who's naughty or nice here. But you know what? This is all very important stuff. And checklists are important in making them and doing them right and being collaborative with the different people. Here today, we've had us 150 years worth of experience, and we're trying to share with you just some things that we have seen. We wish we could have 3-4 hours, but we just can't. So we've just hit that iceberg, and we hope that you understand the importance of a checklist. And so Jennifer's going to come back on in a second because we do have time for a few questions, but I want to remind you, you'll receive an email after this webinar in the upcoming days or in a few hours, as Jennifer says, concerning your CEUs. If you want the handouts, use the email address here. It's hmedu@hmark.com. hmedu@hmark.com. I want to thank you for spending this past hour with us. Be safe and healthy. Jennifer, it's back to you. And guys, let's turn on our cameras, okay?
For a fantastic presentation. Here are a few questions that have come in. Let's see. The first is, the logs we use to track manual high-level disinfection are essentially checklists. Yet it's hard to make sure these are 100% filled in. How can we improve that?
John, would you mind
Yep.
taking that? Sounds like
Thanks,
an endo
Steve.
question.
Well, it's high-level disinfection in general, but often applies in the endo field. I think, well, for one, you need to have those logs, and yes, they are checklists, but the best thing to do, I think, in operationalizing that is to build in per shift, per day, per week, double checks of all those types of processes. Make it somebody's job on that given shift or day to double check to make sure they're complete before staff leave for the day, because the best way to change behavior is to do it soon after.
Okay, thank you, John. Next one, Jennifer.
All right. Before I ask the next one, I did mean to remind the audience that in order to ask a question during this session, please use the question feature on your GoToWebinar dashboard. All right, our next question is, do I need to use a checklist verifying installation of instruments using a high potential tester?
Jahan, you want to take that one?
Sure. So yeah, we talked about testing the continuity of items. Again, you have so many activity going on during the prep and pack that you really need to include that as part of whatever system you have to make sure that you do the installation testing, you do the continuity testing. As sometimes we have 120, 130 items in a tray. If we don't know what we need to do with each items, I think it makes sense to at least have a checklist that did you do continuity testing? Did you do high potential testing on these insulated items? Yes, I think a checklist would be good, or adding it to your count sheet would make sense.
Seth, you also talked about, do you want to put anything in real quick before you get another question, my friend?
I just agree 100%, and that was one of the call outs that I made in my part of the presentation, was all insulated instruments are checked, and there was a sign off, because it's something you got to do. So I agree 100%.
Okay. Jennifer, we got time for one or two more? Well, maybe one. I think it's 1 minute too. I don't know.
I have 3 o'clock on my
Okay.
clock,
Wow.
and so I do try to promise folks that we'll only be here for an hour. So I do appreciate all of your time today. Thank you for a wonderful presentation. Thank you to Healthmark Industries, and just a reminder to our attendees that they will receive an email 1 hour after the completion of today's webinar. Once you complete the survey that is emailed out, you will be able to download your certificate immediately. If you have any questions about this or about any of our webinars, please email me at webinar@mdpublishing.com. For more information on our upcoming 2021 OR Today webinars, please visit our website at ortoday.com/webinars. Thank you all, and have a wonderful holiday season.
Happy holidays, everybody. Season's greetings. Yep. See you guys.
Bye. Thank you.